Becker-Barroso, the editor of the Lancet Neurology, and I am delighted to present the next speaker, Professor Jacqueline Pallas, who is going to give us an overview of pharmacological treatment for patients with neuromyelitis optica spectrum disorder. This lecture will follow up from the beautiful talk that we heard yesterday from Dr. Clemens Warnke on the safety of these drugs. Professor Pallas is a consultant neurologist and a professor at the University of Oxford, and she has had a long and fruitful interest in autoimmune neurological diseases, standing on the shoulders of another giant in this field, Professor John Newsom Davis. Dr. Pallas is now one of the most accomplished clinical researchers in this field and also an amazing mentor and role model herself, especially for women in science. With Michael Levy and Kazu Fujihara, Professor Pallas has contributed a very elegant review on new therapies for neuromyelitis optica spectrum disorder that it was published in the Lancet Neurology a few months ago. And I will invite everybody here to have a look at this splendid paper, which is, I think, very, very useful. Through that paper, I learned that a relative abundance of preventive treatment options now exist for these patients. So I am really excited to learn more about this positive news today. The Lancet Neurology aims to be at the forefront of clinical advances in neuroimmunological research and is therefore a great honor to introduce Jacqueline Pallas for this Lancet Neurology lecture today. Thank you very much.
So thank you so much for that very flattering introduction. I'm really not sure whether I really deserve it. I'd just like to start by making sure that you can see my disclosures. I'm presuming everyone can see my screen here. And to say that as I've just been introduced, I've been asked to cover the treatments of neuromyelitis optica spectrum disorders. So why is Homer looking so distraught? And I just want to remind everybody here that the diagnostic criteria for NMOSD, in my view, is no longer fit for purpose, except for patients who have ACP4 antibodies, whereby all of them, if they've got a clinical syndrome, fall within it. And that's because you've got about a third of your patients with MOG antibodies who fall within it, but the majority don't. And then patients with true antibody negative disease who fall within it. I want to remind everybody that if you have antibodies to ACP4 antibodies, to ACP4, you have a primary astrocytopathy. But if you have antibodies to MOG, you have a primary demyelinating condition. And of course, if you don't have antibodies, we don't really know what the target is or what you have. So today, I thought it would be helpful for you if I actually cover the treatments of these conditions set out here, focused on what the antibody is and on whether they have monophasic or relapsing disease. The first thing I'd like to say very strongly is that, like MS, ACP4 disease is a chronic relapsing condition and should always be treated as such. I'd like to make a point also that antibody negative relapsing disease is not a single disorder. It's not, you haven't got there once you've got the diagnosis. It's heterogeneous. Some of these patients will have a true antibody condition, but some will turn out to have MS, and others will be a mixed bag, including sarcoidosis. So this very simple slide will bring home some important take-home messages that are relevant to treatment. So the audience here will very clearly know that most MS patients will start off with a mild relapsing course, whereas in the antibody conditions, the patients will have these very devastating relapses. The difference is that the ACP4 patients, even with treatment, will often not recover fully, whereas the MOG patients will recover much better, not often to baseline. This will mean that the ACP4 patients will accrue quite significant disability if they continue relapsing. But our main target with these patients, which is different from MS, is to prevent all relapses. And that is what we are always aiming for. Whereas, as you know, with MS, we are looking at more than just preventing relapses. We are looking at preventing all disease activity. The other thing, as I mentioned, is that MOGAD has a monophasic as well as a relapsing course. And as I mentioned, with MS, there is a progressive phase, which is really important for disease and disability accrual, and we don't get that in the antibody diseases. So that means that in clinical trials, relapses are an absolute surrogate for disability in the antibody conditions, and also that time to relapse in aquaporin 4 disease is a perfectly good surrogate for disability, because we don't want patients having lots of relapses when their relapses cause such profound disability, which is irreversible often. So I'm going to talk about treating acute attacks. I'm going to talk about preventing the rebounds after attacks in MOGAD. And I'm going to talk about relapse prevention in all patients with aquaporin 4 disease and in those with relapse in antibody negative disease and MOGAD. So talking about acute attacks, sometimes people call me and they say, I've got a patient and they look like they might have a sort of, NMO relapse, but I need to know the antibody status. Well, you don't, because you treat them all the same. So it's an emergency. You treat them acutely with high-dose methylpred, at least 3 days, up to 7 days. And if they've got a significant disability or they're having a poor response, you really are setting them up for plasma exchange, or IVIG if you can't get hold of it, kicking in with more IV methylprednisolone. And also thinking about a tailor of prednisolone. So you don't just stop it, you're actually giving them prednisolone course while you're waiting for the antibody response. And for those of you in the UK, the hold up is going to be in your lab often. So the turnaround time for the antibody is within a week in Oxford. So will you make sure that the antibody sample is sent from your lab to the Oxford lab? The hold up usually is in the home lab. So what evidence is there for the treatment? So we don't have any great randomized studies, but this is a really great observational study. So this is from a German consortium, and they got over 800 attacks in nearly 200 patients, majority aquaporin 4 positive patients. And as well as analysing all attacks, they split them up into different types of attacks. They compared high-dose methylprednisolone to plasma exchange, and they didn't find any difference except in the transverse myelitis patients. And what they found was in these patients, plasma exchange increased the complete remission rate threefold. So to 30% from 10%. That is, despite the patients being much more severe, because this wasn't randomized, and so they were doing plasma exchange in the worst patients, and they still managed to pull them back from a complete remission. Because it was an observational study, they could look at lots of different outcomes, and they looked at the first treatment versus second line in those who needed it, plus third line, plus fourth line. They didn't see any difference in the complete remission rate, but at the bottom you can see the no recovery rate. And they halved the no recovery rate for second line treatment for just over 16% to 8%. Further treatments gave little benefit, a 1% reduction. It was significant. So second line treatment really did reduce the no recovery group by half. It is worthwhile mentioning, and again, if this had been some sort of randomized study, we wouldn't have allowed late treatment in, but they did allow treatments up to 3 months. And again, we wouldn't have included that into a randomized treatment study. And because they allowed all comers in an observational study, they were able to look at the effects of delay in treatment per day. On a univariate analysis, each day delayed was significant. Multivariate analysis, not quite. I've translated this delay in over time. So you can see here a 7-day delay reduced the chances of that patient completely remitting by 30%. and at 1 month by 77%. So every day you delay your treatment, your patient getting their acute treatment, you are delaying their chances of full recovery. It's really crucial. So coming on to preventing rebound relapses in MOGAD, these patients have had their acute attack, you've treated them, and you're going to take them off prednisolone tailor. They're very sensitive to prednisolone. So this is from an Australian study where they were doing just that. And to the left, you can see they're tailing them off the prednisolone, and it shows you what dose of prednisolone they relapsed on. And they're coming down in their prednisolone dose, and the majority of them are relapsing when they get between 6 to 10 milligrams of prednisolone, so at lower dose. On the right, in the blue, you can see in months when they come off the prednisolone, when they relapse, and virtually all of them are relapsing in the first 5 months. So they're very sensitive to prednisolone. So we recognised very early on that our patients were sensitive to their prednisolone. We wondered how long we should keep our patients on. They've only had one attack. We didn't want to keep them on prednisolone for life. So we looked and had a look and saw how long they were on their prednisolone. And if they were on it for less than a month to 3 months, 3 to 6 months, or more than 6 months. And what we found was if they were on for more than 3 months, then they were at a lower risk of relapsing over time than if they were on it for less than 3 months. And because of that, we now put our patients on for 6 to 12 months. If at 6 months their MOG antibodies go away, which they do in about 20%, we stop the treatment then. If they continue, we leave them on for 12 months and tail it off. Now, in children, particularly if they have ADEM, acute disseminated encephalomyelitis, their risk of relapse is less, and their risk on corticosteroids is greater because of bone growth, and therefore a lot of pediatric neurologists will put them on less or corticosteroids. So coming on now to preventing relapses. So if they're aquaporin 4 antibody positive, they should all go on to treatment. And relapsing MOGAD and relapsing aquaporin antibody negative disease, they should go on to immunosuppression. And the algorithm has always been the same. At the end of this, I will fine tune it for you, but we've always given a very similar algorithm. This is adapted from a paper we published in Practical Neurology nearly 10 years ago now. So I've highlighted prednisolone because these patients are very sensitive to it. If the patient can tolerate usually 10 milligrams of prednisolone, we keep them on it, and we use a steroid sparer. And you can see down on the left, there's a number of them that are given. I would like to say 85 to 90% of patients with aquaporin 4 antibodies are female. So many of them are going to be of childbearing age, and therefore many of them will be on prednisolone with azathioprine. If they relapse when they have been on an adequate dose for an adequate length of time for the drug, then obviously you can swap them on to an alternative therapy. On the right, there are some other options, and I'm just going to go through the evidence, or maybe the lack of evidence, for these different treatments now. So it's well accepted that rituximab is better than mycophenolate, which is better than azathioprine. This is one such study from the South Korean group when they looked at the difference when they used rituximab versus mycophenolate versus azathioprine first time, and you can see patients relapse quicker if they're on azathioprine than rituximab, and the majority of these are aquaporin 4 positive. So coming on, there has been a randomized study of rituximab. It's open label. So it was rituximab versus azathioprine and prednisolone. And on the left here, you can see relapse-free rates. So in blue, azathioprine versus rituximab, and there was a significantly higher relapse-free rate in Ritux. And the pre-relapse rate on the right on Ritux was higher than azathioprine with pred, but on Ritux it was lower. A Lancet Neurology paper, which was a double-blind study of Ritux versus low-dose prednisolone, Ritux in blue, low-dose Pred in red clearly showed Ritux was better. The only thing to say is the low-dose Pred was lower than I would be using in the clinic. Rituximab, however, is not magic. Patients fail. So coming back to that original picture I showed you from South Korea, even used first line, 25% of patients fail. On the right, use second or third line. This study from France, nearly 50% of patients, when it's used second or third line, fail. Really, just to say the evidence for some of the other drugs is literally some case series, but we have a lot of experience. And in fact, a lot of the drugs that we use is from our experience in myasthenia gravis, and John Newsom-Davis was mentioned earlier. So a lot of the work that many of the groups that treat NMO have been using have been using is from their experience in other antibody conditions. I know a lot of the group in the Mayo Clinic had a lot of experience in myasthenia as well. So methotrexate been used for years in myasthenia and rheumatoid arthritis. Cyclosporine been used for many years in myasthenia and other antibody conditions. Just a case series here showing it works as well as azathioprine. Tacrolimus, again used for many years in antibody conditions, used a lot in Japan and China. Actually, we have a few patients on this and it works really well. Cyclophosphamide, I just wanted to mention this. Not a lot on this, but some worrying data. I'd like to point to the little case series on the right, 7 patients from Brazil. 1 patient was lost to follow-up, but 5 of the 6 that were followed up relapsed. 1 died from a severe relapse. There's a feeling that cyclophosphamide may not work, and a lot of us aren't using it in aquaporin 4 antibody disease because of this. Many of the MS drugs make aquaporin 4 antibody disease worse. There's a lot of data now confirming this in interferon beta. I'm just showing you this one nice, neat example because it's easy to see. So you'd expect regression towards the mean. Patients who relapse, you give them the drug, you expect it to go down anyway. Neatly, you can see here the relapses go up. In a fingolimod study in Japan for MS, 1 patient had catastrophic relapses when they started. They then tested them for aquaporin 4 antibodies and they were positive. They went back to 68 patients, found 3 more with aquaporin 4 antibodies, and then noted they'd all relapsed when the fingolimod was started, and they had quite bad relapses. A group of patients with antibodies on glatiramer acetate, they took them off and the relapses went down. Some really nasty reports with natalizumab and alemtuzumab, deaths and severe disability, and some bad reports on dimethyl fumarate. And this multivariate analysis, again from the German consortium, and as you can see, they've compared to interferon beta, which we now know doesn't work very well, found that mitoxantrone performed equally, I suppose, badly to interferon beta. They used to use quite a lot of mitox in Germany in MS, really. Another Lancet Neurology paper of tocalizumab, which is a monoclonal to IL-6 receptor. In blue, tocalizumab. In red, azathioprine. Majority of patients with aquaporin 4 antibodies showing that tocalizumab performed very well. This is time to relapse. Thought this was quite neat, looking at autologous hemopoietic stem cell transplantation. Now, I'm not an expert in this technique, but I'd heard that patients with this tended to get a lot of antibody responses. They tend to get other antibody diseases after. So I'd sort of thought maybe it wasn't the way to go forward with antibody conditions. And I was in one of the Scandinavian countries at a symposium and heard the report from this European registry. And they reported 16 patients. 10 of them had known aquaporin 4 antibodies. This is time to relapse. And as you can see, all the patients tended to relapse over time, which confirmed what I'd expected. This is a Chinese study. They didn't know the antibody status because it was from a long time ago. On the top, it's conventional MS, and on the bottom, the hatch bars were opticospinal MS, so they were an NMO phenotype. And as you can see, time to relapse was much sooner in the NMO phenotype than in the MS patients, again suggesting they didn't do so well. However, a recent study from the US of 12 patients reported very, very good results. So only 2 over 5 years of their 12 patients relapsed. And quite remarkably, 11 of them were aquaporin 4 positive, and at 1 year, 10 of them had become negative. And at 5 years, of the 8 patients they had antibody results on, 6 remained negative, which is pretty extraordinary, actually. Now, the difference may have been in the conditioning regime, and I'm not an expert in conditioning regimes, but what they used in the conditioning regime that is, I think, novel is they used rituximab and plasma exchange. So I understand you've heard a little bit about the new treatments. So I'm just briefly going to compare the efficacy. So satralizumab is a monoclonal like tocalizumab against IL-6 receptor. IL-6 targets B cells, T cells, blood-brain barrier dysfunction, and may also have a role in inflammation in the brain. Inebilizumab is anti-CD19 monoclonal. So in addition to the anti-CD20s, it targets plasmablasts. So we expect it to work quicker because it's more downstream to the antibody response, but also the plasmablasts produce antibodies itself. And then eculizumab is a monoclonal to complement, so it won't have an effect on the antibody itself. We expect it to work really only in aquaporin 4 antibody disease because we don't expect there, from the data we know, to be a big complement activating pathway in MOG antibody disease. So you've seen the target here. The formulations and the way it's given, satralizumab is subcut 4 weekly. Patients could give it at home. Eculizumab 2 weekly intravenously, but there's a formulation under trial which is 8 weekly subcut. And inebilizumab 6 monthly IV, not really very different to how we give rituximab now. The design, satralizumab was an add-on and a placebo study, 2 studies. Eculizumab was an add-on mainly, inebilizumab a placebo, and it was a short study. Tended in the placebo studies to give more of a chance of being on active study and less active patients recruited. The satralizumab study was the only study that actually had a decent number of aquaporin 4 negative patients. The eculizumab study had all aquaporin 4 positive patients. And all studies, as I mentioned, use time to relapse as the outcome, perfectly good in my view for a surrogate for disability over the long term. This is the comparison of the outcomes. So the overall reduction in relapse risk was highest in eculizumab, 94%. You're not really comparing like with like unless you look in the aquaporin 4 positive group, was very similar in inebilizumab and satralizumab. Now, the inebilizumab study was only 6 months because it was a placebo study. In the satralizumab, I've only looked at the add-on because that is more comparable to eculizumab. If you just look at the 96-week results, you'll see the placebo group were 53% and 52% were relapse-free at 96 weeks, and in the active arm, 92% and 96% in eculizumab. So the results for the relapse-free groups don't look as different as if you express the results as overall risk reduction of relapse in the 2 groups. So it does depend how you express the results, maybe. I thought you'd be interested, and I don't know if this data was presented yesterday, the real world data from the hematological registry. I've got a couple of slides on this for eculizumab. Just to say the meningococcal infection rates from the hematologists report 2.5 cases per 1,000 patient years with a fatality rate of 0.3, so 1 in 8 are fatal, without any obvious predilection group for us to really focus on, with serogroup B still being the most frequently reported, and really virtually all cases being meningococcal, having meningococcal vaccinations, not against all serotypes. And their overall conclusion over these 10 years was that the safety profile was consistent from the clinical trials with no new or emerging risks, that they actually had some pregnancy data, which is very useful for us, with a favourable benefit-risk profile, that we don't anticipate different safety data for our different patient groups, and the major risk is from Neisseria infections. Are there any nuances to suggest that we should treat our MOG and our relapsing antibody-negative patients a bit differently to our antibody-positive patients, our aquaporin 4 positive patients? Because previously my talks would lump them all together. So just coming back to the clinical trial, if we now look at the aquaporin 4 negative group in the satralizumab study, we can now see there was no effect. So aquaporin 4 antibody negative patients that fulfill the criteria can't be the same as aquaporin 4 positive patients. In the inebilizumab group, there were only 17 patients, 4 in the placebo, 13 in the inebilizumab group. There were no relapses in that very small number of placebo. There were 3 in the active group. So you can't say a lot because they're small numbers, but there is no signal coming through that it's working. And as I said, there were no negative patients in the eculizumab study. In MOG data, we don't have a lot of good data. This is an observational study where they group azathioprine, mycophenolate, and Ritux together versus no treatment in relapsing MOGAD. And it does appear that those that are on treatment are less likely to relapse over time. That's in green. There is a suggestion that rituximab is less effective in MOG than in aquaporin 4 disease. This is anecdotal data, and the Liverpool lot collected from many centres over 120 MOG patients. They noted that the relapse rate when you went on Ritux was reduced if you used it first time more than if you used it second time. That's not surprising. There will be regression towards the mean, and you can see the effects on the Kaplan-Meier curve. Those used first line works better in. Again, not surprising. I've aligned the axes compared to our first line use from the Korean group in aquaporin 4 disease. It does look better than in aquaporin 4 disease, but it's a different population. Interesting report from the French group where they compared nearly 30 aquaporin 4 patients and about half the number of MOG patients. What they said was that 24% of their aquaporin 4s relapsed at 38 months. 38% of their MOGs relapsed in half the time. But what I thought was most interesting was that nearly all their aquaporin 4 patients relapsed when their B cells recovered, whereas very few of their MOG patients relapsed when their B cells recovered. So I think that's quite interesting. And then finally, just to mention, this has been observed in many other papers before this, but this is just nicely shown. This is some data from the Mayo Clinic from 70 MOGAD patients. These are probability of relapsing. The drugs, some of them will have used a mix of first, second, third line, so it's not really comparing directly equally. But the IVIG was often not used first line. The MSDMTs were nearly all used first line because the diagnosis wasn't necessarily known. And as you can see, patients are far more likely to relapse if they're on MS drugs and least likely to relapse on IVIG. So this is a summary of everything I've told you today. In an acute relapse, doesn't matter what their antibody status is, you treat them aggressively and quickly. IV methylpred, with or without plasma exchange and IVIG. Severe attack, perhaps plasma exchange, get it set up. No further benefit after second line. If they have aquaporin 4 antibodies, immunosuppress and long term, you don't take them off treatment. Rituximab is better than mycophenolate, better than azathioprine, but think about if they're childbearing age. There are 3 new treatments licensed. These are not available in the UK, and don't put them on MSDMTs. If they don't have aquaporin 4 antibodies and it's a single attack and they're antibody negative, still would give them a prednisolone taper over 4 to 8 weeks. If they've got MOG antibodies, we would put them on prednisolone for 6 to 12 months, check their antibodies at 6 months. But if they've got pediatric ADEM, you could probably get away with a much shorter course. If they are relapsing and they're antibody negative and they've got typical NMO, then you just immunosuppress them. If they've got opticospinal MS, and some of them do have, give them MS drugs. But if you're not sure, then play it safe and give them the anti-CD20s. And if they've got MOG, relapse in MOG disease, then immunosuppress them. Now, there are cases where we've had patients who've had, a gap, an interval of 20 years. So if they've had a gap of 20 years, you're not going to put them on long-term immunosuppression. But prednisolone, azathioprine, mycophenolate, perhaps not Ritux from the data we're seeing coming out, IVIG if it's available, and probably not MSDMTs. So I'd just like to thank the neurologists that collaborate with us and all the patients that consent. Thank you.